about cannabinoids for medical ailments. Please give him your warm welcome.
Thank you. Can everybody hear me okay? All right. So my name is Dr Abodeely, and I'm here to talk to you briefly about cannabinoids for medical ailments and a clinical perspective that I've developed over about 8 to 9 years of treating patients with both surgical and medical ailments. So briefly about myself, I'm a board certified surgeon, both in general surgery as well as gastrointestinal surgery. And I've been incorporating cannabis-based therapies for almost 8 years now. And the reason that was because where we live in upstate New York, there's a huge cannabis culture. And I would be treating patients with multiple medical ailments, surgical ailments, and they would come back to me and say, "Thank you very much, but I smoke pot instead and it helps and it's better than any of the medications you give me." So it's been an eye-opening experience. In addition, in addition to treating patients, we've also started we started a company formulating our own products. I also serve as a chairman for the Dispensary Review Committee for the Association of Cannabis Specialists, with our mission being is to educate various educational platforms, but also dispensaries to help with risk mitigation, and also to make sure that what we are knowing or referring to these providers in these dispensaries as bud tenders, which I can't stand that term because it's associating with a bartender. And you don't go to a bar for, well, I guess you kind of go to a bar sometimes for therapy, but you don't go to a bar to treat your medical ailments. This is the world I live in nowadays. And so, you look on the left, I'm operating, I'm removing a diseased gallbladder, and then you say, well, it's a highly regulated environment. The technology we use is highly regulated, the medications we use, the anesthesia we use, the protocols we have to go through. It's so highly regulated, sometimes it becomes unenjoyable. So then how do you go from that? How do I go from that then to go into the office and talking about gummy bears? I mean, it's, and smoking marijuana and things like that. So, although I used to use these two arrows saying, I treat patients in the operating room, medically, surgically, and then I use some adjunctive therapies. Well, now I'm starting to do this, meaning that we can use these to also prevent patients from having to end up in the operating room, as well as treating their other conditions. So my journey, I started practice after I finished my training about 8 years ago, and a lot of my patients, I'm a referral center for advanced gastrointestinal cancers, but also inflammatory bowel disease and other GI conditions. And over the years, of course, you develop patient relationships, and through an admission of guilt, my patients were telling me, hey, you're giving me these medications. A lot of the medications for inflammatory bowel disease, if you're familiar with them, are quite toxic, not fun for patients to have to receive. A lot of them require infusions. And they were telling me, I'm not interested in using that anymore. I've been using cannabis and it helps. And at first I was very insulted because I go through 30 plus years of training, and now someone's telling me that they're taking a gummy bear and smoking pot. And I say, oh, great. So, but what was shocking to me is that the outcomes were real. But this is what I was really faced with, what I call my cannabis medical dilemma. Because from 2010 to 2015, patients come back and they say at work, and I say, well, I don't have an explanation for you. I said, so what I had to do from 2010 to present is just gather all the information I could gain on the science, studied products, started looking at products that patients would bring into me and say, hey, I'm using this CBD-based product, what do you think of it? So I had to do a lot of vetting of these products to determine what works, studying them. I also needed to get, which was very important, is I needed to get buy-in not only from my patients but also from my referring providers. To this day, if you go ask 9 out of 10 doctors what they think about cannabis, they'll roll their eyes and tell you to go away. That's a problem. So, I've been on a mission to try to educate other doctors, to educate them that there is real science to this, there is real validity. Yes, there is some paucity of the data, but we're getting there. And so, in addition to spending all this time, and I did decide to say, well, I got to go to where did all this start? So I decided to, again, as our previous presenter spoke, to travel to Israel, to the Hebrew Institute. Now, if you look at, this is Dr. Raphael Mechoulam, who we consider to be the godfather of cannabinoids. And I'm always fascinated by this picture because this is a picture of him. I can't tell, I've been able to try to look at when the date of this was, but clearly you see cannabidiol with the chemical structure. This was us about a year ago. So look at this age difference. I don't know that age difference. Anyone want to guess? I don't know, 30 years, 20, 30 years. I don't know, I'm a very bad judge with that. But the fact that here we are today talking about this, when he was talking about that, and this complex here, even by US standards, for a hospital complex is a pretty impressive complex. And one of these buildings, this building right here, is a 6-story building which is dedicated purely to the science of cannabinoids. Each floor is dedicated to, one floor is dedicated to cancer, one's dedicated to inflammation, one's dedicated to metabolics. So I spent a lot of time there trying to figure out where is this going, where has it been, what do we think the future of it is, and gained some really knowledge and knew that I wanted to continue to pursue this. So in New York State, prior from 2010 to 2015, I was dealing with non-THC based products for patients that would bring them to me and say, can I use this, should I use this? Or them just saying I smoke marijuana. And of course the problem with smoking marijuana, we have no idea what's in it, okay? So currently, I decided to become certified to certify patients in New York State who meet the criteria in New York State for medical ailments. And currently, this slide's a little outdated. We currently have over 2,000 medical cannabis patients with over 6,000 patient visits. So I've gained a great deal of experience with trying to figure out what works for patients, what doesn't, their feedback. Not only that, but what products work particularly for particular ailments. And there's a lot we have to learn. We have currently a 90% success rate with continuation of therapy. So how do you define success? Well, you can define success as continuation of therapy. Somebody likes a product, it's a shampoo, successful if they keep going back and buying it. Decreased opioid use, decreased medications for things like inflammatory bowel and Crohn's disease, decreased epileptic medications, and then quality of life. And I want to touch briefly about this placebo effect, and I don't know if anyone was at the panel earlier that I spoke to, but placebo effect is a known thing in the herbal compounds. We know that there is a placebo effect, a lot of stuff. Is placebo effect a bad thing? No, right? If it works, it works. Now the interesting thing about cannabinoids is that what we've found is that what stimulates the placebo effect is a particular part in the brain that's high in concentrations in the cannabinoid receptors. So, if you take a normal herbal supplement, it gives you a placebo effect. You think it's working. Cannabis may be doing two different things. It may be conveying a placebo effect, such as other herbs, but it may actually be inducing a placebo effect by activation of the CB1 receptors in the portions of our brain. That has lots of implications. But that's also why we believe that if you look at it, why is there 400 plus different medical ailments which people are using cannabis for? Well, maybe some of that has to do with this enhanced placebo effect. And again, I don't want people to walk out of here saying, oh, it's just a placebo effect. It's not just a placebo effect, but it certainly contributes to it, and I think that's going to have applications for other industries too when you look at other supplements and how they work and how we may be able to get those other supplements to work better as well. So in the process of doing all this, about 20%, really the light bulb that went off for me was, although I could certify patients for THC-based products, 20% of my patients didn't want it for various reasons. They don't want the stigma, they don't want to be high, they don't want a pee test on, they don't want to test positive on a urine test. The other thing is, most importantly, is the fact that they said the THC products don't work for me, the CBD products do. And because the diseases I treat are so much more complex that I think oftentimes they do benefit from THC, I think if I was treating patients that didn't have a lot of these advanced cancers and horrible inflammatory bowel disease, severe epileptic stuff, I would guess that it would probably somewhere around 50-50 of who benefits from non-THC based products versus having products with THC in it. So I started delving into all the products that patients were sending to me, looking at them. I couldn't find consistency in the products. I couldn't find transparency in the products. I couldn't make recommendations on dosing on that. So we started formulating our own products, which we continue to do. So I'm going to talk to you very briefly about some of the more common medical ailments, and some of this may be a little sciencey, and I'm trying to gloss over that, but certainly if you have any other questions, please feel free to contact me. All my contact information will be at the end of the slide. So, routes of administration. This is one of the most challenging things that we face. How do we control dosing when you've got this many different types of routes of administration, which we all know have different bioavailabilities and consistency in the products, because it all has to do with what is the concentration of those cannabinoids within our blood serum. So what are the best options? Well, there's multiple considerations when choosing these different types of options. I'll give you an example of that. Patients with inflammatory bowel disease, inflammation of the intestines, they're not going to absorb edible products. They have lots of diarrhea. I'll have patients that say, I took this pill and I saw it in the toilet 30 minutes later. Well, clearly that had zero bioavailability and was a wasted expense. So, we've had to work hard at trying to figure out, based upon specific diseases, which routes of administration are the best. It's very important. One thing I keep commenting on, I keep harping on, is that we have to prevent big government and big pharma to come in and put the brakes on what we're doing. The only way we can do that is we have to be active about making sure that we're not making false claims and that we keep driving science. So if you're to get asked by a consumer, a patient, whoever, so what can we legally claim about medical cannabis? The answer right now is not a whole heck of a lot. So you have to be very careful of that. Right now, some things that we can state based upon the FDA is that looking at synthetic THC compounds, dronabinol, which is marinol, nabilone, which is sesamet, we know that those are indicated and have been shown to be beneficial for patients with chemo-induced nausea as well as spasticity related to MS. And then we have our plant-based compounds. Cannabidiol, Epidiolex, which everyone's probably heard a lot about recently. And then the only combination plant-based one we have is nabiximols, which is Sativix, which is a 1-to-1 ratio. So just be careful about what you're claiming. You can present data, but you have to be very careful when you're presenting that data that says data that's done in a bench on mice or data that's done on 10 patients that claim that they had better effects does not mean you should be making any claims about this. So I want to talk briefly about some of the more common things that patients come to see me for. One, obviously, biggest, most common, about 50% of our patients come for pain and inflammation. So what is pain? Pain's a defense mechanism, right? You put your hand on a hot stove, it tells you to pull it away. There are four main categories of pain. There's nociceptive pain, which is pain from trauma at our periphery. There's neuropathic pain, where the actual nerves themselves are damaged. Examples of that is diabetic neuropathy or chemo-induced neuropathy. We have centralized pain, which is something like fibromyalgia, which has a secondary peripheral hyperalgesia, and then inflammatory pain. So in order to understand how these cannabinoids may help with these different types of pain, we have to understand a little bit about our normal anatomy and pathophysiology. So start down here, okay? Picture this as being like your fingertips with the nerves. You get stimuli, These stimuli can be external stimuli, mechanical pressure, cold, heat, acid, and then you have internal stimuli. So if you have an inflammatory state. Now what happens is then these inflammatory modulators bind to our cells and our synapse. Then what they do is they travel up the brainstem, and pain is not pain until it reaches the brain, right? So, if you were to sever your spinal cord and then get a cut on your hand, you're not going to feel it. So how does this work? Well, it works at both levels. It works down here at the nerve terminal ends, and everybody's talking about CB1, CB2, maybe some PPARs and some of these other ones, but this is a relatively still not a complete list of all these receptors which are affected by these stimuli to alter the way these nerves fire. And then as these nerve fibers travel up to our brain, they are also blocked through voltage-gated channels and decreased release of GABA, which is a neurotransmitter which causes our nerves to be stimulated. Inflammation and arthritis, right? Arthritis is a huge thing that everybody cares about, especially with the obesity in the country is causing more arthritis. What are some of the mechanisms by which inflammation may occur, or how cannabinoids may affect that? Well, if you look at THC acts at CB2 receptors in the periphery in our mast cells, which are types of inflammatory cells, to decrease the release of inflammatory cytokines. Those inflammatory cytokines are the same ones here that we're talking about. So if you can block the production of these, you can block the production of pain. And it also acts via CB1 to decrease neuron activation at the periphery, but also heading up the spinal cord to the brain. CBD breaks down and inhibits breakdown of our natural endocannabinoids, which we know are beneficial. It also has been shown to decrease inflammatory cytokines. It's a potent antioxidant, and it's also a scavenger of some more toxic compounds. CBC and CBG we continue to learn about, and the way that their mechanism of action is that they work on a variety of what we call transient resilient potential receptors, the cation channels, TRPV1 all the way up to TRPV8. So as a doctor and a scientist, I always have to say, what is the real science behind this? And so although I can't make claims to my patients, what I can do is I can provide them with some weapons or education to say. Now, so the National Academy of Science, Engineering, and Medicine in 2017 put out, which I believe to be a very good review, where it was very comprehensive. They looked at all the studies of different conditions. They classified these studies into level 1 data all the way down to level 5 data. What's level 1 data? Level 1 data is highly randomized control trials where nobody can find flaws in the design study, where level 5 data is expert opinion data. So it's me standing up here and saying, hey, I've got this patient with Crohn's disease. I've treated 5 of them and they all got cured. That's level 5 data. That's useless, okay? It's interesting and it's thought-provoking, but yes, you have a question?
Being an MD and going towards the science, you said you had that period of patients coming in and kind of driving that forward for you. If you didn't have that patient experience, what would you think of the science that exists without your personal experience with patients?
So if I did not have patients coming in, you're saying?
Yeah. So if you just looked at the science and you didn't have that personal experience of patients telling you that it was working,
yeah,
totally, and then obviously looking deeper into it, if you just read the clinical,
I would rely on this.
And that would be enough to convince you.
Absolutely, 100%, because as scientists, we have to, be able to look at data appropriately, scientific data, and be able to know how to interpret it, but also know how to interpret the potential flaws. And these studies were very well done studies. It's not going to get it FDA approved because that's not how it works in the FDA. And the other thing to note is that these are the illnesses or the types of pain that they were looking at. So again, everything from neuropathic pain cancer pain, MS, rheumatoid arthritis, musculoskeletal pain, chemo. So it really covers majority of the pain. What about acute pain? We're all talking about chronic pain, chronic pain, chronic pain. As a general surgeon, this just came out in September 2013, which was a very short article, but what was very exciting to me is that people are starting to pay attention in my field, okay? And the article is Cannabis and Surgical Pain, Worth a Look. It was a very short article, but it listed several studies in just a very quick blurb about it, how it may benefit. Now, I will tell you right now, I have patients who come in on cannabinoid therapy before they go to surgery, and they say, I don't want to take pain meds afterwards, I just want to use my marijuana afterwards. And I say, okay. You know, if it's no opiates, I'm fine with that. Half of them I send home with a prescription for opiates just in case, because I don't want to get called at 2 o'clock in the morning because their marijuana's not working. And so some of it depends upon how big of an operation it is and things of that nature. But this is very promising, okay? And this is also going to drive this. And I've hung this up in the locker rooms of my surgeons, and 1 out of 10 of them say, hey, that's interesting. The other 9 out of 10 are still a little bit ignoramus when it comes to that, and rip it down and say, I'm not interested in that. But they'll lose. So what do we know about pain? We know that the science is getting there, but still we have to be careful with claims. What we do know is that there's been very good success with opioid addiction, getting patients off of opioids. We have an opioid program where we're able to start patients out on a cannabinoid therapies, and we monitor them closely to reduce, and we've had very good success. Not 100% success against getting them off of all the opioids, but if we can decrease that opioids even by down to 25%, there's real benefits to that. And also we've shown that decreased drug-related complications, overdoses, and things like that have been seen in states with legal medical cannabis laws. That's important, and that's going to drive legislation as well. Another question I get asked, will cannabis help my anxiety? Well, what about my depression? I link these together. Why? Because anxiety and depression are they're kind of one and the same. Most people that have anxiety will have a degree of depression. Most people who have depression will have anxiety. They feed off of each other. So one thing that I ask patients if they're interested in, I say, well, we could put you on products. First thing they say is, well, I can't use that stuff. It makes me paranoid. What cannabinoid tends to make people paranoid? THC. However, in lower doses, that may not be the case, and we've experimented with lower doses, and it has worked well. However, for anxiety and depression patients, I still recommend non-THC based products first, because I don't want to exacerbate any potential. So how might this work? Well, cannabinoids increase transmission of serotonin. What are some of the medications we use for depression and anxiety? Selective serotonin reuptake inhibitors, right? And they've also shown that in patients who have depression and anxiety, their hippocampus, which is a portion of our brain responsible for long-term memory, but also for anxiety and depression, those patients tend to have lower volumes of hippocampus, and when they're given cannabinoid therapy, they've actually shown that hippocampus increases. So that's some pretty powerful data. If you look at what about just pure plain isolate CBD? Well, there's only really been one decent randomized controlled trial where they looked at 600 milligrams of CBD versus a placebo, and they did find a statistical difference in subjective symptoms of anxiety. And then there's been 4 randomized controlled trials which have looked at our current FDA-approved drugs, dronabinol, nabilone, and nabiximols, which have all shown subjective improvement in anxiety. Social anxiety disorder, okay, I stand up here and I'll tell you the way that they did this study was that they gave patients a placebo, they gave patients cannabis. Then they had them do what I'm doing, stand up in front of an audience, and they tested them looking at anxiety symptoms. And what they found was that there was a significant reduction in anxiety symptoms. They then correlated that to brain flows to particular areas of the brain that drive anxiety, and they found that those flows to those brain portions was lower. Again, very good supportive evidence, but we still can't make that claim. But these are things that I talk to my patients about, and some examples that I that I use for them. And again, going back to what the National Academy of Science Medical Engineering states on this is that there is limited evidence that cannabidiol is effective treatment for improvement of anxiety symptoms as assessed by public speaking test in individuals with social anxiety disorder. So they're saying, now just because it says limited evidence doesn't mean that it's not good evidence. It just means that we need 10 more studies before then they're going to say this is high quality and we can believe in it. Question I get asked all the time, I get phone calls, families, patients. Hi, Dr. Abodeely. My name is Linda Smith. My mother was recently diagnosed with cancer, and I think she should use cannabis. Can you help us? All right. First thing I talk to them about is say, well, there's 3 main reasons people use or want to use or consider using cannabis therapy for cancer. The first is pain. Certain tumors are very painful, as is the chemotherapy itself, which can cause significant, neuropathies. And I'm going to just refer you back to the previous slides on pain to let you determine why that works. The second thing is chemo-induced nausea. The third is some people want to use this as a chemotherapy agent in and of itself to help cure cancer. Do you have a question?
You can finish it, but yeah, I have one. I just didn't know how there's mixed information when you're reading on taking CBD during chemotherapy due to the vacuum of the cytochrome P450.
Yes. And I'm going to touch briefly on the cytochrome P450, I believe, in this presentation. If not, ask me at the end, and I will answer that. But that's a great question. So besides pain, we'll talk about nausea. Okay, nausea is regulated at our central nervous system, but also peripherally, and with which we know CB receptors are active in those areas. And so this has been something that we know there's conclusive evidence. So going back to our National Academy, there is conclusive evidence that oral cannabinoids are effective antiemetics in the treatment of chemotherapy-induced nausea and vomiting. Again, we can't legally claim that because this is what they put out, but this is support that you can use, that I use, to say why it may help. And if you look at cannabis versus conventional pharmaceuticals, which they've done, they've shown that some of our older antiemetics, the outcomes are better, if not the same, with cannabis as opposed to those older conventional. The newer upcoming antiemetics, yet there's no good studies on that, but people still prefer that. This is a complicated slide and it's very scientific-y, and I don't want to get into much, but what about CBD as a chemotherapy? Okay, there are numerous potential mechanisms of actions aimed at selectively targeting actively dividing cells. And all these things I'm listing here on the left are the same way that conventional chemotherapy agents work. They want to halt growth cycle of cells. They want to decrease blood flow to those tumor cells. They want to adapt our immune system to be able to fight those cells. And they want to induce apoptosis, which is cell death of abnormal cells. So this didn't project well, but it basically lists different cannabinoids and their potential mechanisms of actions and the studies that have been quoted. So what I will say about cannabis as a chemotherapy agent, it's promising for, right now there's studies saying it's promising in preclinical data for breast cancer, prostate, colorectal, skin cancer, hepatocellular, lymphoma, meningiomas. But there is insufficient evidence to support or refute. So again, the data is promising, but it's just not there for them to be able to make that formal statement. But here's important, and I ask everyone, please pay attention. Activation of some of the cannabinoid receptors may actually increase and accelerate cancer growth, depending upon which cannabinoid receptors are stimulated, depending upon what other non-cannabinoid receptors are stimulated. So we have to be very careful with that, and eventually this is going to become targeted therapy similar to the way our chemotherapy agents are, meaning somebody has cancer, you're not just going to throw a full spectrum cannabinoid product at it. You're going to have to determine what kind of cancer it is, what sort of biology that tumor is, because not every colon cancer is the same. Right now, for example, with colon cancer, is once I remove a section, I send it to our pathologist. They look at our microscope, but then they also send it for testing for various different chemical markers. Then from there, they tailor their therapy based upon those markers. So not every colon cancer gets the same chemotherapy. I predict that's the way that this is going to go as well. So be careful when you're talking to patients about cancer. Don't tell everyone who has cancer, here, take this. You may be doing them a disservice. Gastrointestinal issues. I'm familiar with this just because as a GI surgeon, I get asked these questions all the time. Inflammatory bowel disease, I'll talk a little bit about. Irritable bowel syndrome. IBD and IBS always get confused. Even on some of the cannabis educational forums, the educators here are still intermixing these, IBD versus IBS. They're very different. Mechanisms of action is very different. And gastroesophageal reflux disease, which I don't have a slide for, or I don't have these, so I'll talk about these briefly. GERD can be beneficial. However, depending upon terpene levels and which terpenes you're using, we've experimented with lots of different products in varying cannabinoid and terpene concentrations, and there are certain terpenes at particular levels which people say it gives them extreme GI upset or significant reflux. Now, having said that, there's also some terpenes which are beneficial for GERD, so we have to kind of tease that out a little bit more. Colorectal cancer, I kind of touched about with the previous cancer studies. Cirrhosis is interesting, okay? We talk about, you talked about, well, what about with chemotherapy? And, all these drugs, majority of drugs are metabolized by the liver. Patients with cirrhosis, you say, well, you probably shouldn't have that. Right now, there's two things that we know about cirrhosis and cannabinoid therapy. One thing that we know is that activation of the CB1 receptor, bad, actually increases fibrosis of the liver. However, activation of CB2 has been shown to be a fibrinolytic and actually decrease the amount of inflammation and scarring within the liver and may actually reverse some of the effects. So again, everybody with cirrhosis, they're not a candidate. Once we find ways to target that CB2 receptor and other potential receptors, we may be able to actually help decrease that. And we're finding that in lung disease as well. Different sorts of COPD and other interstitial lung diseases where activation of this may actually decrease fibrosis and improve pulmonary function. And obesity is a whole nother ball of wax. Everybody thinks of marijuana making you fat, okay? Patients come to me, they say, I don't want to use it because it's going to make me fat. And I say, it's not going to make you fat, it's the Doritos that are going to make you fat, okay? The reason being is that when you use particularly THC-based products, it causes euphoria. We know that it causes euphoria with food, with watching TV, with sex, you name it, all right? It increases euphoria. So if you sit down with a bag of Doritos after you smoked a joint high in THC, those Doritos are going to taste pretty good, So you just got, but the other thing about obesity is there's been numerous studies that have shown that people who are habitual users throughout their whole life actually have lower body mass indexes, BMIs, lower weights, and less incidences of diabetes, which is directly, of course, related to weight in a lot of cases. So so let's talk a little bit more about the GI tract. The GI tract is full of the endocannabinoids. It's very rich in all of this endocannabinoid system, both at the neuron level within the walls of the intestines, but then also at the mucosal level. So some of these effects can include decreased intestinal motility, hence why it helps with irritable bowel syndrome, particularly diarrhea-predominant irritable bowel syndrome. Decreases acid secretion. You can have alteration, and I shouldn't say alteration as much as I should say enhancement in GI mucosal epithelial barrier. I got asked earlier a question about leaky gut, right? Some of the people are talking about what is leaky gut. Well, we don't fully understand leaky gut, but basically our cells are all next to each other, and if they're not nice tight to each other, they don't have good junctions between them, bad stuff can sneak between them, get into our lymphatic system, end up in our system, and potentially cause a variety of illnesses. It alters our immune function, and then of course appetite stimulant / suppressive effects, because there are some cannabinoids now which are showing decreased appetite. So inflammatory bowel disease, I won't get into this too much. It's a horrible condition. It's a tough condition. It's an autoimmune condition where your body attacks itself, but it attacks the GI tract. There's been very good relatively good, I should say, animal models, preclinical research that shows that cannabis extract and CBD treatment results in decreased inflammatory cytokines, because it's all has to do with inflammation. In human models, we do have some studies coming out, multiple, again, non-randomized controlled trials. So what I can say right now about inflammatory bowel disease is that it is very beneficial. It is beneficial. We believe it's beneficial. However, we need a little more data. Irritable bowel syndrome, just because we're running a little short, I'm going to just go through that. But just the take-home message is that I do believe there's significant value in decreased abdominal pain as decreased frequency of bowel movements. Extreme caution with terpenes, okay? Too high level of terpenes, particular terpenes, can cause GI upset. And with our products that we formulated and tried around with until we got it right, we had a lot of people that said, my symptoms got worse. So until we got it right. So not trying to pitch our products, but this is our products. Reserve MD. We're a launch company. We are launching. We've got 4 different products right now. We are still looking for strategic partners in all of this venture. I want to thank you, and I want to thank CBD Expo. Few take-home messages, and this is somewhat of a call to action. We must continue to advance science and education of cannabis therapies, or we're going to lose to big pharma and we're going to lose to the government. Okay? We also must collaborate to educate, formulate, and provide affordable access. This is my contact info. Please feel free to reach out to me if you have any thoughts, questions, and we'll go from there.